Dr. April Allen is the Anticoagulation Clinical Program Manager at the VA North Texas Healthcare System and is a clinical pharmacy specialist in anticoagulation. She serves as the co-chair for the Veterans Integrated Service Network, or VISN 17 Anticoagulation Work Group Committee, which works with 7 sites across the state of Texas to improve anticoagulation services. Furthermore, she's received several VA courtesy and action recognitions for providing quality patient care and customer service. She was the creator and coordinator of the Coumadin Initial Visit Education classes for the Anticoagulation Clinic at the VA as well. Dr. Allen has publications and posters presented on her work in anticoagulation. Her most recent collaborative VA poster presentation won first place at the Texas Society of Health System Pharmacists and the TSHP Research and Education Foundation competition in September of last year. In November of 2020, Dr. Allen was appointed to co-chair the Anticoagulation Forum IDEA, that's Inclusion, Diversity, Equity, and Allyship Committee. The Anticoagulation Forum, or the AC Forum, is a national multidisciplinary organization that provides information and best practices on anticoagulation. She received her Doctor of Pharmacy degree from the University of Tennessee in 2002 and completed a pharmacy practice with ambulatory care emphasis residency at the Regional Medical Center in Memphis, Tennessee in 2003. Next on our list as a panelist is Nicole Crooks, who is a nurse practitioner. She's originally from Toledo, Ohio. She received her Bachelor of Science in Nursing from Mercy College of Northwest Ohio in 2009. She later went on to obtain her Master of Science in Nursing Education from Lourdes University in Sylvania, Ohio in 2012. And most recently, she obtained her Primary Care Adult Gerontology Nurse Practitioner Certificate from Kaplan University in 2015. Due to encouragement from her advisor while at Lourdes University, her capstone project was published in the Association of Black Nursing Faculty entitled Mentoring as the Key to Minority Success in Nursing Education, and this was in 2013. Throughout the course of her RN bedside career, she worked at a level 1 trauma center in their neurological ICU for 2 years and later transferred to their medical surgical trauma ICU for 4 years. Her nurse practitioner experience includes Medicare in-home assessments, substance abuse, addiction, mental health, hospice, and primary care house calls, and CBOCs servicing veterans. Currently, she works with veterans performing compensation and pension examinations. When not practicing, she loves to spend time shopping, traveling, and helping out the community with her sorority, Zeta Phi Beta Sorority Incorporated. Amber Howell-Jeans attended undergraduate university at the University of Texas at Austin. She graduated in 2019 with a Bachelor of Science in Kinesiology. She went on to further her education and graduated from the University of Texas Health Science Center in San Antonio in 2018 with a Master of Science in Respiratory Care. In her free time, she enjoys gardening and baking. Dr. Sylvia Perry is a nationally recognized pharmacist, a 2-time best-selling author, a podcaster, a speaker, and a consultant specializing in pharmacy implementation and administration. Through her consulting programs, Dr. Sylvia builds profitable pharmacies by helping pharmacy owners enhance their offerings and expand their reach to serve more patients. She's the founder of PharmD Consultants of Texas, which provides consultant pharmacists throughout the state. Along with her brother and father, Dr. Sylvia is a historically Black university graduate, earning her Doctor of Pharmacy from the renowned Xavier University of Louisiana. In 2018, she was honored for her work as part of the 40 Under 40 Young Alumni Awards. She credits her HBCU experience for molding her into a servant leader and forming her can-do attitude. Dr. Sylvia is passionate about public health, advocating for equal access to care, reducing the white coat stigma and health disparities in the Black community, personal health and wellness, and serving the elderly. She helps busy caregivers become the best caregivers for themselves and others through her video series, books, products, and services. Dr. Sylvia resides in her hometown of Dallas, Texas. With her expertise and experience, it's no wonder that Dr. Sylvia is known as the pharmacy strategist. And she even has her own website. And you can connect with her at www.drsylviaperry.com.
So we're going to be talking, well, I'm going to be talking about the Delta variant. So we'll start off with the basic, what is COVID-19? At this point, we've kind of been living in this pandemic for quite some time. So unless you've been living under a rock, you should be very familiar with COVID-19, but if you're not, there it is. It's a respiratory disease that at this point is having multiple systemic effects on people who do get this disease. It was first reported in China in December in 2019, and then shortly here in the United States in Washington State near the Seattle area on January 21st of 2020. Next slide, please. So COVID-19 mutations, which is kind of where we're at today in regards to the Delta variant. So in general, all viruses mutate, meaning that there is a possibility that they can change as time goes on. And sometimes those mutations can have a very, very small effect, and other times they can have a huge impact. Mutations in the realms of viruses, it can affect how easily the virus spreads, which we'll talk about in a little bit. It can affect the severity of the disease, which we will also talk about. It can affect the performance of vaccines and other therapeutic medications, which we'll talk about that too. And it can also affect like the diagnostic tools that are used to diagnose that. So quick example, you know, right now we're using the nasal swabs and the buccal swabs to try to get those negative positive tests. So that's what that part would be. Next slide. Oh, and it's currently, the mutations right now are currently being monitored by WHO, or the World Health Organization is who is responsible at this time for tracking all of these variants that you will see on the next slide. So next slide, please. So COVID-19 variants. So obviously the one of concern right now is Delta, but there are other variants out there. The other one that has been in and out of the media recently is the Mu variant. So I have them all listed here, as well as when they were first documented by WHO, the World Health Organization. So Delta originally was documented in October of 2020 in India. If you look here at the slide, you can see that all of the variants underneath Delta, Eta, Iota, Kappa, Lambda, and Mu are all variants of interest, whereas Delta is a variant of interest as well as a variant of concern. And we'll talk about that here in a second, but Delta became a variant of interest on April 4th of 2021, and very shortly thereafter, May 11th is when it became a variant of concern. So it progressed very, very rapidly, and the people who are monitoring COVID became very concerned very, very quickly. So next slide, please. So exactly what is a variant of interest and what is a variant of concern? So here is a quick, in a nutshell, box of those two. So a variant of interest is the top two boxes that you have there. So it's something, a virus, bacteria, whatever, that is predicted or known to affect the characteristics of a virus. So those characteristics can be how contagious the virus is, the severity of the disease, and then the diagnostics and stuff like that that we just talked about. So if they know it's going to change some properties of it, as well as increase the prevalence in basically a multitude of clusters. So, you know, not just here in Dallas, but in the United States as a whole, as well as other countries too. Variant of concern has those same two properties of a variant of interest, but it also includes those three things at the bottom of the table. So they know that it's going to increase the contagiousness. And we know that Delta, they've been saying, is very, very contagious, more contagious than the previous variants that we've had out here. Or a detrimental in the epidemiology of the virus. So basically, the distribution, the patterns, that part is super, super sciencey, but I think for the basis of this presentation, just know that if they know it's going to be more contagious, that's one of the things. Or it can increase in the virulence or change the clinical presentation. So basically, how sick are these people? Is this particular strain making people sicker than what we were previously seen. And if you've been watching the news, you know that they are saying that these people who come down with the Delta variant have been much more sicker than the people previously. And then the last one is the decrease in effectiveness of public health and social measures, I'm sorry. So basically what that is, I'm sure you've heard, you know, the back and forth with the vaccines where they're saying the Delta variant may or may not be, or the current vaccines may or may not be as beneficial towards Delta as they were the previous strains of the disease. So like I say, Delta is one that is meeting multiple of these boxes, which is why it is so, I don't want to use the word dangerous, but which is why it's so big, so prevalent, and why we need to be cautious. Next slide, please. So COVID-19 in Texas. So majority of the people on this call are from Texas. Those who are not here in Texas, March 10th of 2020, our governor told us that we no longer needed a mask mandate, basically left it up to an honor system. If you were vaccinated, great, you don't have to wear a mask. If you were not vaccinated, then the recommendation was to wear a mask, but it's all honor system. The ending of this mask mandate also came with the ability for businesses to go back to functioning at 100% capacity. So I think prior to, we were at maybe like 50 or 75%, but the mask went away as well as increasing capacity all at the same time. So if you can click that info thing. So for those here in the state of Texas, this is a very great and interactive site for you to manage all things COVID related. It is a .gov site, which means it is very highly credible. And I'll briefly touch on that at the end. So if you can go to case counts on the right-hand side, yep. So this first screen is going to populate the state of Texas as a whole. On the right-hand side, it'll be all of the different counties. It'll bring a map up here in the middle in just a second, and you'll be able to see like the major cities: Dallas, Houston, Austin, El Paso, San Antonio. So if you're just, we're not going to discuss this, but this right-hand side, like I say, if you click your county, it'll give you all types of information that you ever wanted to know. So right now here in Dallas County, you can see where we're at confirmed cases wise. Harris County, which houses Houston, they do have more cases than us. If you could go to under the number 346, where it says over to, yep, trends. Perfect. So when COVID first came out, you know, numbers were everywhere. Every single time you turned on the TV, you would find some type of COVID numbers and statistics. As time has went on, though COVID is still very media driven, those numbers have kind of disappeared. So for the state of Texas, this is where we're at. I constantly say we're worse today than we were a year ago, and this is going to prove just that. So if you look at the purple graph in the top left-hand corner. Oh, yours are different than mine. So let's see. You can see on the left-hand side, we got the 2020. And if you go to like the peak of that first mountain, so keep going up. Up. So like there, that was what, June or July 14th, we had 10.7 thousand cases. And you can just kind of see how it's just been peaks and valleys. You can see where we had a very low valley, and that valley, if she scrolls over and kind of plays around and toggles them out, you can kind of, no, the one closer towards 2021, the second. Yep. That was, we first started to decline shortly after the vaccines became available. So vaccines became available to the general public in December of 2020. And shortly thereafter, we were making some great progress. As you can see, we went up, we came down, and now all of a sudden we're back in this upward trend. And then if you look at this upward trend. Like I say, Delta became a variant of concern on May 11th of 2021. And very shortly thereafter is when all of these numbers started to spike out of control again. So yes, we have made progress in the realms of the vaccinations, and I will let the pharmacists talk about that. But as you can see, like I say, with Delta, our numbers have completely just gone off the radar, back to exactly how we were pre-vaccine. And then if you go to the bottom right-hand corner, this aqua green one, this one is just the deaths. So you can kind of see that same thing. We spiked up, we came down, we spiked back up, we came down, was doing really, really good. And then now all of a sudden we're back on this upward trend and the numbers of deaths that we're having from COVID. And then lastly, if you go back to trends beside it, the demographics tab. So this slide isn't, well, not slide, but this page is important. This goes back to where I talked about the change in clinical presentation of a disease. So if you recall, when COVID, quote unquote, first came out, it was a disease of elder people, people 60 and over. It was a disease of those who had chronic illnesses. This particular page is accurate as of September 17th. And you can see that 60 and plus age, those numbers, yes, they're there, but they're lower. If you go to this 20 to 59, you can see that's where the bulk of our recent confirmed cases are coming from, is that age group. So whereas before, that younger adulthood, that 20 to 59 was quote unquote the safe age to be in, because like I say, this was a disease of those 60 and up. You can see how that trend has changed, going back to that variant of concern definition that we talked about, and you can see how it's now affecting those who are younger. So for those in the state of Texas, this is a great website to go to. It's super, super interactive. I won't discuss anything else on this site, but definitely a good website to go to kind of look at COVID here. So if you want to go back to the slides. Next slide. So because I have personally invited some people from California and Ohio, I did plug you guys in right here. But really quick, if we can go to that info button, this will link us off to the CDC website. And really what I really want you to get out of this one, if you go to right up underneath that map, state level community transmission. And we'll let this, yeah. And so if you scroll down just a little bit, a big map of the US, yep. So when I created these slides late last week, California was orange, and it was a couple states, maybe like Connecticut and Massachusetts, some stuff over in that side of the US that were orange as well. When I came to the site today, the only state that is red or that is orange right now is California. If you scroll down just a little bit, it'll tell you what the colors mean. So high, substantial, moderate, low, no data. So like I said, last week when I checked, there were a few spots that were orange, but for the most part, everything now is in this huge, high, super, super contagious mark. And if you click, you don't have to click, but if you come back to this site, once again, very credible site, cdc.gov. If you hover over the states and you click it, it will take you to their sites that are tracking. So like if you was to click Texas, it would take you to the site that we were just on. Same for all of those states. So that's another website that's super, super interactive, very credible resource in the CDC. That's it for that. And we can go to the next slide. And so why the spread with Delta? So it's much more contagious. The increased social mixing and mobility. So basically the lack of social distancing. The relaxation of public health mandates. So basically, whereas before we were all, the entire United States was under a mask mandate, many states Many states have dropped that mask mandate. So the lack of masks with getting together back in large groups is not helping. And then the uneven and inequitable distribution of vaccines is also playing a role. And this graphic here just shows you how contagious the Delta variant is compared to the original strain of COVID that we were dealing with when this first became a thing. Next slide. And so if you click this really quick, this is just another resource. We won't discuss it, but it's the World Health Organization, which is also a very credible resource. If you scroll down just a little bit. So they have all of these episodes here. They all are 5 minutes or less. And she can keep scrolling, but it's a multitude of different topics on anything that you can think of pertaining to COVID. Episode 45 is specifically about the Delta variant, but there was an episode previous to that one about the Delta variant as well. But it just has all types of information in regards to Delta. Like I say, all these videos are less than 5 minutes long. So this is another very credible source to go to if you have any questions pertaining to COVID. And next slide, which I think is just the references. So here's my references. My only spill with references is if you're online, make sure you're going to credible websites. Your .govs, your .ints, and your .edus are going to be your best and most reliable sources of information. Not saying that you can't go to a .com, but if you go to a .com, that typically involves you having to fact check those sites. So if you can stick with things like the CDC, World Health Organization, another one that I normally use is National Institute of Health. It's not up here, but that's also a very good and reliable source.
My name is Mra Vaccines. I'm a respiratory therapist. Kind of just a quick down and dirty of what a respiratory therapist does on a day-to-day in the hospital is we do breathing treatments on the floors. We kind of manage oxygen with patients that require oxygen. And in the ICU, we take care of ventilators. Any patients that have to get intubated, we're right next to the physician, assisting with those intubations. And then also in some states, we do have license to intubate patients as well. So we can go to the next page. So just a quick kind of anatomy overview of what is involved in the lungs. We see the larynx, which is kind of like your vocal cords, your trachea, which is how the air gets down into your bronchi and bronchioles. And then you see in the small little sac there are your alveoli. Now, your alveoli are where gas exchange happens from CO2 to oxygen. So we're intaking oxygen through the air that we breathe, and we are getting that into our lungs to be distributed through the blood system. And most of our body creates CO2, and that is exchanged there as well to get so we can expel CO2 out of our system. And go to the next slide. So this is just a quick kind of comparison of just normal lungs, x-rays versus a smoker's lungs versus COVID lungs. So when we think about just normal lungs, we see nice air aeration. You should have a nice black x-ray because that means like there's enough airflow coming in. And when we compare it to the smoker's lungs, you see that there is some infiltrates and things of that nature, as well as they have increased airspace because they're air trapping, and they do have some kind of congestion, sputum and stuff like that. So you have what you call smoker's lungs. But now when you compare it to a COVID lung, this is a complete whiteout of your lungs, because before in the previous slide, we saw the alveoli. Because this is an acute respiratory disease, the virus attacks your alveoli, closing them down, making them unable to exchange that CO2 and O2 in your lungs, which is causing other issues in going into hypoxemia, having you have cough, fatigue, fever, shortness of breath, and excess sputum production. And then we can go to the next slide. So what does this mean for patients? Like I said, you're going to get some hypoxemia, and those that are unable to maintain their oxygen saturations on a normal. So what we've been doing in the hospital is, if someone has decreased O2, which as you can see on the chart next to the side over here, is that anyone below 75 is severe hypoxia, has severe hypoxia. Generally, these are assessed through a blood gas. But the easiest way, because that's an invasive procedure, the easiest way to measure someone's like kind of how they're saturating and their oxygenation levels in their bloodstream is with a pulse ox. I think a lot of people have seen them. And when people are satting below 80, 85, or even into the 70s, we generally typically go ahead and put them on oxygen. And some of these patients have been requiring higher flows of oxygen. So when we think of low flow devices in the hospital system, we think of less than 15 liters. And some of our patients have been requiring up to 60 liters. And when you think about oxygen concentration, the air that we breathe in a daily is at 21%. And that should be enough to maintain your oxygen levels. So when we're having to increase oxygen, give them 50 to 60, the most you can get up to is 100%. And some of these patients that we've been seeing in the hospital are at 60 liters and 100% FiO2, and they're still destatting. And this is because there's no bloodstream. It's pretty much what's called shunting. So there's no way that your alveoli can exchange that O2 CO2 due to the fact that there's blockage in those lungs because of the alveoli are pretty much in shambles and damaged. So you're not going to be able to have that proper CO2 O2 change. So where you're seeing the CO2 rise, as you can see on this pH value, we as a human, just humans in general, have a homeostasis, and our homeostasis pH is 7.35 to 7.45. And when we're acidotic, that's going to creep downwards. And generally, that's a lot of times when people have CO2 issues, you're going to see that CO2 creep up and you're going to see that pH drop. And with that, that's pretty much what we call is acute respiratory distress. And for that, patients get intubated. When they are unable to maintain oxygenation, which a lot of these patients, again, have been having those problems because their lungs are completely whited out. So they get intubated. And right now at the Baylor Scott and White Network here in the Austin area, 92% of the patients on ventilators are unvaccinated. And as well as my hospital I work at for Ascension, about 90% of the people that are on ventilators are unvaccinated. Unfortunately, we have to deal with the problem of people one lady, she was very adamant about, well, vaccinated people are getting sick as well. Well, this is true. The overarching 90% to 10%, I would take my chances with the 10% versus the 90, and the fact that patients, mostly we are seeing Mexican males just because of the demographic in the Austin area. No underlying conditions, nothing else has been happening. The main thing that we do see is the number one factor is unvaccination, and it can quickly turn from them coming in with fatigue or just a cough and dyspnea to having to get intubated pretty quickly. And that is the one thing that has been the most prominent is the unvaccinated status. So again, it's just kind of with that, what can we do to help? And I think a lot of people especially my age group, and as you saw before, the younger age group, I think a lot of people hone on that they're fine and that, oh, well, I'm healthy, I'm young, I don't really need to. I think you don't want to be you don't want to be that person that thinks that and then things turn quickly. So we'll go to the next slide. So pretty much from the study below, the most severe lung complications that they've seen are tissue hyperinflammation, fibrosis, scarring, lung collapse, and organ death, and as well as from that patient death. Due to the fact that it is an alveolar damage kind of disease process, because when you don't get proper oxygenation into your lungs, you're causing other body systems to not get the oxygenation that they need to run. So if you don't have oxygen in general to breathe and whatnot, and kind of so we're starting to see multi-organ failure as the disease process progresses. And once that starts to happen, it's kind of hard to come back. And even though some people are able to come back from the brink of death, meaning that they've been intubated from long time, put on nitric, they are having severe complications in the long run. So their quality of life has decreased from post-intubation as well. As well as a study by Rodin. They had patients that were impacted with COVID have had vast alveolar damage. So you see a lot of people that still say, like, I'm having problems breathing, I'm having a severe cough, and just things that could be prevented, taking those measures of getting vaccinated and making sure that you're maintaining social distancing, and really trying to all of us work together to kind of help push us out of this pandemic.
Imagine a year ago what the world was like without COVID-19 vaccines. Since the inception of these COVID-19 vaccines that came on the scene back in December of 2020, we've been able to give out millions and millions of these vaccines worldwide. So I ask you this evening, what more do you want to know about the COVID-19 vaccines? Next slide. In the 2021 census that was taken recently in the United States of America, we have over 333 million people. Out of 333 million people, there have been over 386 total vaccines administered right now. And that was as of last night on the CDC website at 8 p.m. Eastern. And that website gets updated every evening around about 8 p.m. Eastern. Out of doses that have been administered, over 182 million people are fully vaccinated, meaning that you have had 2 doses of these vaccines, or either one dose, depending on if it's the Johnson & Johnson vaccine. And at least over 212 million people have had at least 1 dose given. As far as unvaccinated individuals, they make up greater than 90% of all cases of COVID-19, hospitalizations, and death. And you heard Amber allude to that in her slides, in her presentation as well. Next slide. These are just some vaccine stats I would like to share with you. As you can see, the graph over on the left-hand side looks at the total number of doses administered of the vaccines. The Pfizer vaccine has been administered over 221 million times, Moderna over 149 million times, Johnson & Johnson, about 14.8 million doses have been administered. And then we've had some that over 367,000 that were not identified yet. On the right, this graph shows the total number of people that are fully vaccinated. Over 99 million people have received the Pfizer vaccine, and that's one that I received. Over 67.7 million have received the Moderna vaccine. About 14.6 have received the Johnson & Johnson vaccine. And there have been over 104,000 people reported that have received either a dose of the Moderna vaccine or the Pfizer vaccine. They just can't remember which one they received. Next slide. So why should you get vaccinated? It's quite simple. You get vaccinated to help to protect you, your family, your friends, and your community from COVID-19. Also, the vaccines give you a better chance of survival if you contract COVID-19. After looking at the pictures that Amber put up about those lungs, it really is a scary thing to get COVID-19 to see what your lungs look like. Also, the vaccines help you to prevent getting the long haul COVID-19 side effects or death. And right now, we're still learning in the medical community some of the long-term side effects that people are seeing. There are cardiovascular side effects people are getting, blood clots, difficulty sleeping, people losing their hair. And this is just the tip of the iceberg of things that we're starting to see in the medical community. And of course, one of the most main important reasons to get vaccinated is to help to decrease the spread of COVID-19 and also we're depleting our medical resources. If you have not been watching the news lately, I've been paying attention, our hospitals are full right now. If someone's in a simple car accident, they're not even guaranteed to be able to get into the ICUs to get the proper care that they need, because most of our hospitals are full with COVID-19 patients. Next slide. We have 3 different COVID-19 vaccines that are available here in the United States. We have 2 mRNA vaccines, which is the Pfizer and Moderna vaccine. These vaccines were both approved for the FDA emergency use authorization back in December 2020. And yes, the FDA did approve these for authorization. That's one myth people like to talk about. When these are not approved by the FDA did give emergency authorization use. In order for a drug in general to be given emergency authorization use, the drug must show at least 50% of efficacy and being effective and at least have 2 months of adverse effect data. For a drug to even get approved by the FDA, you need this greater than 50% efficacy, but at least 6 months of data for adverse effect data. These drugs were approved for emergency use authorization for ages 18 and up. But as of August 23rd, a few weeks ago, Comirnaty became the first FDA full approved COVID-19 by Pfizer. Comirnaty is used for the prevention of COVID-19 in people 16 years of age and up, and also it still has emergency use authorization for children 12 and 15 years of age, and for the 3rd dose for the immunocompromised patient. Next slide. And our 3rd vaccine is known as a viral vector. And this was also approved emergency use by the FDA back in February 2021, and it is for ages 18 and up. Next slide. So let's talk about what is messenger RNA vaccine. It's simple. mRNA vaccine or messenger RNA is just a carrier of genetic code that's made from DNA, and plays a very vital part in our human biology. And the science of mRNA has been around for greater than 10 years now. It is new, but it's been studied for more than 10 years. I've even heard one report that this was being studied back in the 1960s. So for people that are concerned about this is new, it's been around for a while. We just have not been able to use it, because when they first tried to use mRNA, it was very unstable, like within the flu vaccine. But thanks to modern technology, we have been able to improve the stability, the safety, and efficacy of using mRNA. Basically, for mRNA vaccine, it's a set of genetic instructions that goes to the cells and tells the cells to make proteins to prevent or fight disease. It's not like a live virus like the flu vaccine is. So there's no risk of causing disease after you get vaccinated. And also, these vaccines do not enter the cell nucleus, so therefore it does not impact or affect your DNA. So you're not gonna have any genetic code authorization within your genetic code. You're not gonna grow an extra eye, an extra ear, or extra leg. As you all can see, I look pretty normal, and I've been fully vaccinated since January the 12th. Next slide, please. The simple mechanism of action of these drugs is to be able to take the genetic material known as mRNA, which is inside a special coating. This coating helps the mRNA get inside the cells, and once it gets inside the cells, it sends a message that says to make the spike protein located on the surface of the COVID-19 virus, known as SARS-CoV-2. The cell then destroys the messenger RNA once the message gets delivered, and it does not enter the cells. So overall, the cells start to display the spike protein. Our immune system recognizes that that protein is a foreign substance and does not belong there. Then it starts to produce antibodies against it, and that's how we get our immune response to protect us against future infection. Next slide. So let's talk about the mRNA vaccines a bit more in depth. The Pfizer vaccine is a vial of frozen liquid stored in a very ultra low temperature or freezer. Usually stored at -70 degrees when it's frozen, but now Pfizer is able to be stored in a regular refrigerator for 30 days now. This is the one that we have to dilute with sodium chloride in order to activate it. For every vial of this Pfizer vaccine, you get 6 doses out of it. But once it's diluted, it expires after 6 hours. So that's the reason why it's very important, if you have an opportunity to take it, that you take it within a timely manner. You get 2 doses of this vaccine administered. You get one at baseline, and then 21 days or 3 weeks later, you get your second dose. It's a 0.3 milliliter dose that's being injected into the upper deltoid muscle of your left or right arm. This vaccine has shown that when it's at full capacity, which is 2 weeks after your second dose, to be 95% effective at protecting you against COVID-19. And of course, it does come with some adverse effects, which are things that are like flu-like symptoms, fever, chills, headache. You get pain at the injection site. You can get some arm soreness, redness, and swelling. And you can treat these adverse effects by simply taking Tylenol for 24 to 72 hours, and those symptoms tend to go away. You also can get some severe adverse effects like fatigue, headache, and anaphylaxis. And anaphylaxis is pretty much just like swollen lips. It could be swollen tongue. It could be anything that causes you to have to go to the ER. Next slide. Your second mRNA vaccine is the Moderna vaccine, and it's a vial of liquid stored in a freezer. It can be stored for up to 30 days there. 1 vial equals 10 doses and expires 6 hours after you open it. So once again, these vaccines are time sensitive. It's 2 doses as well. You get your first shot at baseline, then you get your second shot at day 28. And the dose for this one is 0.5 milliliters into the upper intramuscular as well. 2 weeks after your second dose is shown to be 94% effective against protecting you against COVID-19. Very similar adverse effects like you would get with Pfizer: flu-like symptoms, pain at the injection site, arm soreness, redness, and swelling. And then, of course, the same severe side effects, which would be fatigue, headache, nausea, bumps, and anaphylaxis. But the one thing that Moderna can do that's kind of unique on its local reactions, that you can still get redness, hardness of soft tissue, itchiness around the injection site. And some of these symptoms are delayed up to, can occur after your first dose all the way up to the second week. My mother experienced this when she took the Moderna vaccine. She did not have any symptoms the first week. The second week, she started having these things. So sometimes Moderna can give you a delayed reaction at the injection site. So if that does happen, you just take your injection in the opposite arm that you had in the first time around. Next slide. So let's talk about viral vector vaccines. And most people probably don't even know what a viral vector is, but pretty much it's a modified version of another virus known as the vector, and that is harmless, that enters our cells to deliver instructions. This has been used by scientists since the 1970s. It's safe and it's effective. It cannot cause you to have COVID-19 or enter the cell nucleus to impact your DNA either. Hence, the mechanism of action of this one is pretty simple. The vector enters the cell to deliver instructions to make a harmless piece of COVID-19 known as a spike protein, just like the Pfizer vaccine and Moderna vaccine does. The spike protein gets displayed on the cell surface. Our immune system recognizes it as being a foreign substance. Then it makes antibodies against it. And once again, the body learns how to protect against COVID-19. So different mechanism of action, but similar mechanism of action. Next slide. With this vaccine, this is the J&J vaccine made by Janssen. And this one can be stored in the refrigerator for up to 6 months. 1 vial gives you 5 doses. Once again, it expires after 6 hours. Open it, and this is only 1 dose, and it's 0.5 milliliters into the upper deltoid muscle. The efficacy of this vaccine is only 72% after 2 weeks after taking it, compared to the other 2 that are 94 and 95%. Similar common adverse reactions would be flu-like symptoms, pain at the injection site, arm soreness, redness, and swelling. But however, back in April of this year, we did find out that this vaccine was causing some rare blood clots with low platelets. And so women that were less than 50 years old, and there was about 46 cases of this that happened, were experiencing blood clots from this medication and low platelets. And also some people, there have been reports of over 600 people getting syncope after taking this, feeling faint-like with this drug. But the one good thing about it, out of that 46 that did have blood clots, over 14.5 million people had taken that vaccine without any complications. Next slide. Booster doses. I know you've been hearing a lot about booster doses in the news media lately. And I know we've already given out 2 million booster doses. And I do know some people have received their booster doses a little bit early, and some people are still trying to get booster doses right now. To be honest with you, the jury's still out on booster doses. We're still trying to get conclusion about information on the booster doses. But a booster dose mainly it's used to help to provide a stronger immune response several months after receiving your second dose of your messenger RNA vaccine or after your first dose of your viral vector vaccine. What has been shown is that the Pfizer and the Moderna vaccines have both lost some of their efficacy over time. And so basically the booster dose is given just to kind of boost you back up to that 94-95% efficacy level. Right now, the Pfizer vaccine and Moderna, even though it's not come out to be proven yet with the FDA, can be used in immunocompromised patients that usually after 6 months, a patient that's considered immunocompromised can get a third shot. Immunocompromised are people that are HIV, cancer patients, organ transplant patients, patients on high dose steroids. They're not patients that have diabetes, high blood pressure, high cholesterol, or asthma. You're not considered immunocompromised. So please keep that in mind. Last Friday, the FDA did meet, and so the FDA did not approve booster doses for the general public. Right now, the FDA is supporting using booster doses in patients that are 65 or older. But once again, the jury is still out on this. I think over the next week or two, we'll be getting more up-to-date information about booster doses, and I do think the CDC is meeting again tomorrow. So don't be surprised if this information is changed by this time next week. Next slide. So facts, not myths about COVID-19 vaccines. They cannot cause you to have COVID. They cannot change your DNA because they do not enter your cell's nucleus. These vaccines have the same safety assessment like any other vaccine or any other drug that's come to market. They just had an accelerated timeline without skipping the steps because of the need that we have for the pandemic. And all these vaccines have been put in large clinical trials, and a safety board data review has been done on them. And these vaccines can be taken by pregnant women. And studies have shown that pregnant women who take the vaccines can pass antibodies over to their children or their newborn child, basically. The vaccines right now are not interchangeable. I know if you get Moderna, you want to get Moderna. If you get Pfizer, you want to get Pfizer. Same thing with J&J. So right now they're not interchangeable. So please do not try to interchange these vaccines. And the overall main point is these vaccines teach our cells to make a protein that creates an immune response, antibodies to protect our bodies from virus infection. Next slide. These are some of the resources that I used to put this presentation together. These are all great resources. As Nicole said, you always want to go to something that has a .gov behind it, basically. And this will help you to find good information about these vaccines. And also talk to your healthcare providers, trust your healthcare providers, and talk to them about getting vaccinated if you're still concerned about the vaccines. Social media, rumors, or conspiracy theories are not good resources for learning about these vaccines. So once again, I ask you, what do you want to learn about these vaccines? Because now we've been out with these for about almost 10 months now. And so we have a lot more information now than what we had a year ago. Thank you.
Well, hello. I guess I am bringing up the rear. Thank you to everybody for such great information. And I just need y'all to hold on with me a few more minutes. I'm going to talk about monoclonal antibody treatment, and I am Dr. Sylvia. So I think I'm going to say most of us on this call are vaccinated, and hopefully if you're not, these presentations have answered your questions. But what options do you have if you're vaccinated? We are seeing breakthrough cases, and then we have people that are not ready to get vaccinated yet. So the monoclonal antibody treatment is something that we all should know about and how to access it. And that's what we're going to discuss briefly today. Okay, so we're just gonna make it real simple. I'm gonna go over, everybody remembers question words from grade school. So the who, what, when, where, and why of monoclonal antibodies. I see the yeses, okay, popcorn style, good. So that's what we're gonna discuss in these next few minutes. Go ahead and go to the next slide. What are monoclonal antibodies? So monoclonal means it's an identical cell or protein, and they're considered clones because they pick one that they want to replicate, and they'll make clones of those. It's derived from a single cell. It's genetically distinct because we want to make sure it's a little different so that we know that this monoclone is targeting what we want it to. And all the molecules are the same. Antibodies, as we have discussed earlier, that's part of our immune response. It's a naturally occurring protein in our body, and it's produced naturally by our body when we detect a harmful substance called antigens. Next slide, please. So monoclonal antibody therapy or infusion treatment, these replicate antibodies, but they're made in the lab. They're not made inside of our body. They're delivered by infusion, IV, subcutaneous, using a catheter inserted into the vein. And there are over 100 types of monoclonal antibody treatments. 100 types. I think the first one was introduced in 1975, and then it got approval for use in the late 80s, around 1986. And they are currently used to treat asthma, cancer, Crohn's disease, and rheumatoid arthritis, among other things. For COVID-19 monoclonal antibodies, this one is specific to the SARS-CoV-2 or coronavirus, and the antibodies block the virus from entering the cell. So do y'all remember what we played dodgeball in grade school when they were still playing that? It's a little dangerous now, I think. It was dangerous back then, but I didn't break any bones. So just think about that. You're all lined up, and then these antibodies help block the virus from entering the cell. So that's what it's doing to help keep you not having an infectious process and getting into the cell and starting that infectious process. It was authorized for emergency use by the Food and Drug Administration. So I really wanted to take a minute to highlight this point. There are a lot of people that are weary or very concerned about vaccines, and I know it all happened so fast. It was new. I feel like there are very legitimate concerns early on about these vaccines that came all of a sudden. They were there. And I want to honor that feeling and concern. But like Dr. April said, it's been 10 months and we have a lot more data, but a lot of people have embraced the monoclonal antibody therapy, but it's under the same emergency use authorization that the vaccines are under. So you have emergency use authorization for vaccines that prevent you from getting severe disease or dying in most patients, or you have something that you can use after you've gotten infected, a positive COVID test. That's also an emergency use authorization to help you not have severe disease and hopefully not death as well. So I just want to make that very clear. It's the same emergency use authorization. I'm glad that we have this therapy available. I'm glad that we have vaccines, but they're using the same authorization. So just consider that, and maybe that's the point you want to bring out as you're talking to your loved ones. And then it's 2 medications combined in one, given together, and there's 2 companies that are making them. I think it's a unique time in medicine. We never refer to drugs by their manufacturer, but everybody's like, I got the Pfizer vaccine, I got the Moderna vaccine. And so now with these monoclonal antibody therapies, Eli Lilly has one that combines 2 different medications to treat you. And then Regeneron is the company that has the other one. I'm sure you heard that in the media a lot as well. Next slide. Who's eligible for this treatment? So it's authorized for individuals with mild or moderate COVID-19 and adults and children 12 years or older. And you must weigh at least 88 pounds. You have to be positive for COVID. So, you know, we saw those pictures of the lungs that Amber showed us. Some people, they may stop testing positive for COVID, but they may still be having trouble with their breathing, lost taste or smell, just a myriad of symptoms, because COVID can really do a number on your organs. But that person would not be eligible for monoclonal antibody therapy because they are no longer testing positive for COVID. Also, you have to be high risk for progression to severe COVID-19, possibly leading to hospitalization or death. So that's who it's authorized for. Next slide. Who is not eligible for this treatment? Hospitalized due to COVID-19. So this was news to me as I was preparing for this presentation. If you're hospitalized, you're not eligible for this therapy. So if you're requiring oxygen therapy because you have a positive COVID test or have COVID-19, or if you're already on oxygen and your oxygen needs have increased, you're not eligible for this therapy. So, you know, once it gets bad and you have to go to the hospital, this is not an option for you. So this is the option for somebody that hopefully was vaccinated, unfortunately got a breakthrough case, or if they weren't vaccinated, they got tested and they were positive for COVID, and they go to an outpatient center to get monoclonal antibodies. But if their breathing gets so labored that they need to go to the hospital or they get admitted to the hospital, this would not be an option for them. And what I learned as I was preparing is those people that are getting oxygen or are on a ventilator, they may have worse clinical outcomes if given this therapy. So that's one reason why those patients are excluded. Next slide. When should you seek out therapy? It's pretty clear. We all know what ASAP means, as soon as possible. And it's because of the reasons that I just listed before. So you get a positive test, you're doing fine, you're checking your pulse ox, it's above 92, and then day 5, it's trending to 91, 90. I think Amber said once they get in that 80 range, they may be a candidate for getting some type of intervention. So we want to get this therapy as soon as possible, because once, like I've already just said why it's important. So next slide. Why? It's the best treatment we've had. We've really had an up close view to the STEM science community as we've gone through this pandemic, and things have changed so fast. So whereas a year ago, we didn't have this therapy, we have something that can help in an outpatient setting to keep you from getting severe disease. So it's the best treatment we have for people that already have a positive COVID test. Regeneron is seeking FDA approval for its monoclonal antibody therapy, and they are touting that it reduces symptoms by 31%, and then by day 3, it reduces it by 76%, and it also lowers that viral load. So that's really promising as well. So hopefully very soon it will have its hearing like the Pfizer vaccine did back at the end of August and get FDA approval. The vaccine, the other reason why we should seek out this therapy if you have a positive COVID test is the vaccine is not fully effective until 2 weeks after the second dose, as Dr. April let us know. And then COVID infection has harmful, deadly side effects. We saw the lungs, that's very dramatic. Also, it's doing organ damage. People with COVID we're seeing more people that have had COVID that are having blood clots than we're seeing people that got vaccinated that are getting blood clots from the vaccine. So you're at a greater risk for blood clots from having the actual COVID virus, SARS-CoV-2 virus, than you would if you got vaccinated. A very small percentage of people with get the blood clots from vaccination. So, and then monoclonal antibody therapy, the antibodies can start working before your body mounts its own immune response. So it's kind of like calling in the troops. You know, we could sit here, or let's not say troops. We're in the parking lot and we're in a fight. You know, we could beat this person up by ourselves, or we could have a peace treaty, talk it out, whatever means to get to the other side there is. But sometimes you need a mediator, or somebody, you need your big sister or your big brother or whoever to come in and help you out in that situation. So that's what the monoclonal antibodies do. However, that short-term protection, vaccination is still needed. So those antibodies are not going to sit around in your body forever, and it's not going to help you with what they call active immunity. So a person that has gotten this therapy and is doing better, recovered from their symptoms, they would still need to get vaccinated as well, so that they can have that long term and bring in the other components of the immune system that help our bodies recognize and attack antigens going further in the future. Next slide. Where can you access this therapy? Outpatient locations are all over the country. You should screenshot this slide for those phone numbers. But also, if we can click on that green button, this is an online search tool where you can put in your zip code and see what facilities are getting shipments of monoclonal antibodies to your local area. So that will be specific to you and that zip code that you put in. And that may be a quicker way to see who has that therapy versus calling the phone numbers. Okay, next slide. And there's one more question word. It doesn't start with a W, it starts with the H. So who's gonna type it in the chat? What question word did I leave out? Uh-oh, did y'all leave me? I'm by myself. Oh, there we go. Thank you, Sarah Latoya. Thank you. How? So we need to discuss, how do you access this therapy? All right, I see you, Hattie. Thank you. Let's go to the next slide. So we learned who it's for. It's for patients that aren't hospitalized with a positive COVID infection, 12 and older, 88 pounds or heavier. What is it? It's a antibody therapy that is made in a lab that helps you with, helps you fight off the SARS-CoV-2 virus. When should you get it? As soon as possible. Where should you get it? It's done in an outpatient setting all over the country, and the supply is being regulated by the government. So there are some hiccups with that, kind of like we saw early on with the vaccine. And why should you get it? If you are positive, if you have a positive COVID infection, it's one of the best treatments, and it keeps you out the hospital as well, generally speaking. So that's why you should get it. How? Let's go ahead and go to the next slide. How to access. So be proactive. A week ago or a week and a half ago, if you got a positive COVID test, I would tell you run to the outpatient center that is giving people monoclonal antibodies. Because there are hiccups in the supply chain, I'm not going to use the word ration, but some states, I just read that Tennessee is maybe doing some type of reservation for people that are vaccinated with breakthrough cases to access this therapy. So there might be, I'm not going to use the word ration, but people that are unvaccinated may be a little less able to access this therapy. So that literally changed in the last 7 days, about people being a lot more strict about who can access it and who can't. Before, if you knew about it and knew how to get access to it and you showed up, you, in most cases, I can't speak for every state, could get this therapy. So reach out to the center near you using that phone number or that search tool. Ask them directly, do you have this therapy? If they don't, ask them when they're getting their next shipment, because I checked on this website and it says you are getting this shipment or this treatment. And what is the right criteria for receiving therapy? Each state has their own criteria. Some centers may have their own criteria. So you need to know that. And I think that's important to know before you get sick, or hopefully you never will, but I think that's important to know in general. And it's something that is changing. Like I said, 7 days ago, it was a little different. call your doctor. So if you find yourself in a position that you are positive and they say, no, you're 35, you're healthy, just monitor your oxygen level, take all your vitamins, rest, you should be fine. Call your doctor. Ask them if they have a relationship with the facility that's giving monoclonal antibody therapy, and ask them to call that center and advocate on your behalf why you need to get this therapy. Another thing I want to point out is this therapy is free, just like the vaccines. Legislation was passed where this therapy is provided free to anyone that needs it or can access it. And then third, make a plan. So we hope this day never comes. We hope you do not get a positive COVID test and that this goes away. But we're in month 19, 18, 19 of this pandemic. So that's probably not going to be the case for a while. So make a plan, share your plan, and take action. And above all, don't wait. Try to get this therapy as soon as you can. Next slide. Let's keep in touch. If you have questions or want some of these links, you can email me there. And that completes my presentation. I use some of the same, you can go to the next slide. All the information I found was at these sites as well, .govs.